Case 6, a 10-year-old boy has come to a clinic. Complaints of intermittent outward deviation. That means intermittent exotropia. Intermittent means sometimes there is deviation, sometimes there is no deviation. Okay. So sometimes there is outward deviation, sometimes there is no deviation. Okay. So intermittent complaint of intermittent outward deviation noticed from 2 years. So the child's mother come and complain that when the child looks at distance, sometimes the eyes, one of the eyes will go out. And this has started from when the child was 2-year-old. Okay. Earlier only when tired, now most of the time of the day. That means previously the child, when the child was tired, feeling very sleepy, that time one of the eyes will go out. Okay. But now it is happening for most of the time of the day. Means whenever is looking at a little distance, whenever the child is looking at the mother's face, the eye is going out. Whenever the child is looking at distance, it is going out. Okay. No diplopia, no complaint of regular vision. Now we see the refraction. Let's come to the refraction part. So uncorrected vision is 6/6, both eyes. Retinoscopy and acceptance is plus 0.25, 6/6. So plus 0.25 we do not, normally we need not to give. Why will not give? Because the patient is having an exotropia, intermittent exotropia. Okay. So definitely will not give this plus 0.25. Okay. Now the NPC is 7 centimeters. That is quite okay. The near point of convergence is quite okay. Cover test unaided 20 distance. There is 20 prism exotropia. Okay. 20 prism exotropia for distance. Near it is 5 prism exophoria. Okay. This one means exophoria. So definitely the patient is having exotropia at distance. Near the there is a 5 prism exophoria. That means the child was having an intermittent exotropia from 2 years of age. Gradually, as it was not treated, as the tropia part, it was not taken care of, gradually the intermittent exotropia has become a permanent exotropia. Okay, so intermittent exotropia, also we call it intermittent divergence squint. So from IDS to exotropia. Okay, so that is the main problem. Now if we see, there is a 20 prism exotropia for the left eye is going out. So if we do not treat the child at this age, what will happen? 10-year-old child, okay, he is not complaining of diplopia. Okay, so if there is an alternate exotropia, chance of getting amblyopia is less. Why? Because each eye is fixating. Okay, if there is an alternate exotropia, if both, I mean, sometimes my right eye is fixating, I'm seeing that object, sometimes my left eye is fixating. Okay, so both eyes are working. So if my both eyes are working, there is no chance of getting amblyopia. It's very less chance. Okay, so but here you can see 20 prism exotropia mostly in the left eye. If we do not treat this child at this stage, the left eye will become amblyopic and there will be a permanent left exotropia. So when the child will be normally looking straight, the right eye will fixate, left eye will always be out like this, and there will be the exotropia amount will increase day by day. Okay. So we need to treat the child as a stage, only 10-year-old child, we need to treat it. But you can see the near point of convergence is 7 centimeter. Okay. How can it near point of convergence 7 centimeter? That means the patient is having good fusional abilities also. That means that's why he can see single at 7 centimeter. Now when you have done the basing, Basin test, we find distance there is suppression. Near there is 10, 16 and 12. Base out for distance also there is suppression. Left suppression is there. Near it is quite okay. X, 15 and 10. Okay. So if there is a suppression at distance, that means whenever the child is looking at distance, the left eye is suppressed. The left eye is suppressed. That is the reason the child is having no diplopia, no double vision at distance. Normally the child was supposed to have double vision at distance if his both eyes were working properly. But at distance, what is happening? There is suppression. So both the negative fusional divergence and positive fusional divergence, base in, base out, both it is at distance, there is suppression. Now checking the AC by A ratio, it is 12:1. It is higher AC by A ratio. NRA is plus 175, that is low. That means the patient's negative relative accommodation is low. PRA is also low, that is minus 1.5. So PRA basin for near, if we no, it's okay. PRA value, if we like correlate with the AC by A and basin for near, PRA value is quite okay. NRA is low. Okay. The accommodation is right eye, left eye, it is 13 diopter. Monocular accommodative facility is 4 cycles per minute. Binocular accommodative facility is 3 cycles per minute. MEM retinoscope, it is plus 0.25 diopters. That means there is a lead of accommodation, a little lead of accommodation. So what may be the case? Yes. So what should be the case? Yes. What is the diagnosis? Can anyone tell me? Yes. What should be the diagnosis? Yes, what should be the diagnosis? Distance, it is 20 xt, 20 prism xt. Near it is 5 prism exophoria. AC by ratio is 12:1. Yes, 12:1. That means it is a case of excess. So what excess? What type of excess is it? Okay. So basically, anyone would like to try?
Divergence excess?
Correct. Divergence excess. It is divergence excess basically with an intermittent, with an exotropia at distance. Okay. So it is a case of divergence excess. Okay. Now, how to treat the child? Definitely, we are not going to give any refractive correction for the child. It is plus 0.25 because plus power, if you are giving, it will increase the exotropia. Now, coming to the cover test, 5 prism esophoria, 20 prism exotropia. Sorry, 5 prism exophoria at near and 20 prism exotropia at distance. So, if the child was having a minus or a myopia, we should have given the full correction. Suppose the child was having a minus 1 diopter myopia, if you could have given that, though, because AC by ratio is higher, 12:1, so it should have corrected a 12 prism of exotropia also. Okay, but the child is having a plus power, so we cannot push minus. What we can give, we need to train the patient for like the problem, that is there is divergence excess. So that means we need to make the patient converge or normally look straight. So at distance, the patient needs to look straight, right? So what we can do? We can start with the boxing exercise. Definitely the patient can see the nearest bit properly. Okay, there will be no diplopia, there will be no problem, no eye strain, nothing. While the patient is focusing at the intermittent bead, that time he will have a blur vision, he can have a double vision. That means the bead is getting double. Normally for Brockstein therapy, it is based on physiological diplopia. So when you look at the bead should be single and the string gets double and you appreciate the pattern. So when the child is looking at near, he can appreciate the pattern. He can see the bead to be single and V pattern. At the intermediate, he can see the bead to be single and there may be a he can may appreciate a X pattern, or maybe he is seeing a like the bead is becoming double. And for distance, definitely he cannot focus at the distance bead. So what you can do? See, if the patient is having 20 prism exotropia, so you can do one thing. You can train the patient, you can give vision therapy to the patient along with minus lenses. If the patient, okay, if the patient cannot see the distance bead to be single, intermediate bead to be single, give a minus 0.5 or a minus 1 to the patient. See, with the minus 0.5, if the patient is improving, because minus 0.5, 6 prism of exophoria will be normal, but he is having a 20 prism exotropia, so it will be difficult for the patient. But still, see, if he can do the exercise with a minus 0.5, suppose he cannot do, so give a minus 1, so it will be easier for him. Now, when you are giving minus 1 to the patient, that means